Major trauma and multiple injury patients. Mechanism of injury. We have penetrating injuries, blunt injuries. Penetrating injuries, low-velocity injuries caused by knives, spikes of glass, other sharp objects, bullets fired from pistols, low velocity. High-velocity injuries caused by firearms, caused by rifles. Blunt injuries, road traffic accidents, fall from a height or direct blows. Causes of trauma mortality, immediate death, early death, and late death. Immediate death occur within few minutes after the accident, relatively rare. Examples: a major trauma to brain or upper spinal cord, injuries to the heart or major vessels, rupture of major airway. Early death occur within hours after the accident, prevented by rapid and proper management, includes IC hemorrhage, intracranial hemorrhage, massive intra-abdominal or intrathoracic injuries or major fractures. Late death occurs some weeks after the injury, usually due to sepsis or multiple organ failure. Organized trauma care. Victims are best treated by well-organized and trained trauma team. Accident and emergency departments should have equipped resuscitation area to receive major traumatic victims. In mass casualty accidents, triage is important. Patients sorting according to their clinical need and available resources to provide treatment. It may take two forms. If number of casualties or facilities, all injured are treated. If number of casualties is more than facilities, the critically injured most likely to survive are treated first. The American College of Surgeons developed Atlas ATLS accepted protocol for the management of major trauma victims into three elements: primary survey resuscitation, secondary survey, and definitive care of individual injuries. Primary survey resuscitation to identify and treat any immediately life-threatening condition at site of accident by trained ambulance personnel. Secondary survey, full examination, complete history, integration of all available data, formulation of a management plan, definitive care of individual injuries. Primary survey resuscitation, ABCDE. Airway, A. Clear the airway from vomit, blood, or foreign material. They should be removed manually by finger or sweeping or with rigid sucker. This is followed by chin lift or jaw thrust. Protect the airway. An oropharyngeal or nasopharyngeal tube prevents the tongue from falling back and occluding the airway in an unconscious patient. Tracheal intubation is indicated with apnea, risk of aspiration. Airway compromise, inhalation injuries, maxillofacial trauma, closed head injuries allow hyperventilation due to decreased intracranial tension. Cricothyroidotomy, not suitable for children. Method: by making a cut and inserting a tube, or by percutaneous insertion of a wide-bore needle. If the patient is capable of speech, his airway is patent. All patients receive supplemental oxygen by mask upon hospital arrival. Tracheostomy is rarely needed in ER. Nasotracheal intubation is safer if cervical spine fracture suspected, or orotracheal intubation needs the use of a larger tube. Then we have cervical spine control. The cervical spine considered unstable if examination, bony abnormalities, or cervical tenderness are present. Multisystem trauma, blunt injury above the clavicle, altered consciousness level from trauma or alcohol intake. Maxillofacial trauma, immobilization is done by using backboard or rigid collar. If a collar is not available, manual inline immobilization. Radiological evaluation, at least 3 cervical spine views, lateral, anteroposterior, and odontoid, is done later after stabilization of vital systems. Breathing assessment, inspection for chest movement, respiratory rate, cyanosis, jugular venous distension, open chest wounds, asymmetric expansion, the use of accessory muscles of respiration, palpation for subcutaneous emphysema and flail segments, percussion of hyperresonance or dullness, auscultation for upper airway sounds, stridor, wheezing, or gurgling, and for lower airway sounds over the lung fields. Life-threatening thoracic conditions, TOM, FC. T. Tension pneumothorax. O. Open pneumothorax. M. Massive hemothorax. F. Flailed chest. C. Cardiac tamponade. Tension pneumothorax, needle decompression followed by intercostal chest tube. Open pneumothorax, occlusive dressing, fixed at 3 sides only, followed by chest tube. Massive hemothorax, chest tube, then thoracotomy if bleeding continues. Flailed chest, intubation and PPV. Cardiac tamponade, needle pericardiocentesis followed later by operative pericardiotomy and controlling the source of bleeding. Circulation, shock, hemorrhagic, the commonest. Tension pneumothorax, decreasing the ventilation rate, venous return and worsens it. Cardiogenic, tamponade and myocardial trauma. neurogenic spinal cord injury. Sites for hidden hemorrhage are intra-abdominal, intrathoracic, and fracture of pelvis and femur. Action: controlling hemorrhage by direct pressure. Insert 2 large cannulates, 16 gauge, peripheral IV lines plus or minus central venous line. Blood samples sent for typing, cross-matching, hemoglobin and blood chemistry. Bringer's lactate solution is infused as a start. Volume of crystalloid needed equals 3 times estimated blood loss. When cross-matched blood is available, infuse immediately. IV fluids and blood are given at a rate that ensures an optimum urine output of 0.5 to 1 milliliter per kilo per hour for adults. D. Disability. Brief neurological assessment. Common causes of neurological deficits related to trauma, head injury, shock, hypoxia, alcohol or drug abuse. AVPU evaluation. According to best response, alert and interactive. Vocal stimuli elicit a response. Painful stimuli are needed to produce a response. Unresponsive. Exposure and environment. Remove all clothes using sharp large scissors. Keep the victim and place warm to avoid hypothermia. Insert urethral caster, Foley's caster, to monitor urine output. Contraindicated if there is blood at urethral meatus leading to urethral injury. Insert nasogastric tube or Ryle's tube to decompress the stomach and prevent vomiting and aspiration. Radiological examination for blunt trauma, cervical spine, anteroposterior view for the chest, pelvis, x-rays. For penetrating trauma, anteroposterior view for the chest, and x-ray of trauma site. After resuscitation, other x-rays or CT scans if indicated. Proper history taking. AMPLE, amply. A. Allergies. M. Medications. P. Past medical history. Last meal time. L and E for events of injury. In analyzing the causes of death in major trauma, 3 interrelated factors, hypothermia, coagulopathy, and metabolic acidosis, make a vicious circle, potentially fatal outcome. Hypothermia slows clotting factors, leading to coagulopathy. Coagulopathy leads to decreased tissue perfusion. Anaerobic metabolism, leading to metabolic acidosis, so warming of the patient by blankets or warm IV fluids is essential. 5 causes of upper airway obstruction: tongue, blood, loose teeth, vomitus, soft tissue, edema. Secondary survey. It includes examples of head and neck for hematoma, fractures, and pupils, face and spine by 4 persons who turn patient's body into one piece, log rolling, to avoid spinal cord injury in unstable spine fracture, chest and abdomen, perineum, including PR in all patients and PV in females, limbs for fractures and soft tissue injuries, including vessels, nerves, and tendons, nervous system, pupils for size, equality, and reaction to lights, Glasgow-Coma scale, cranial nerves, sensation and motor activity in the limbs, CT scan of the head if there is suspicion of intracranial injuries, definitive treatment of individual injuries according to its site. We have 5 main features of respiratory distress, which are tachypnea or dyspnea, using accessory muscles of respiration, difficult speaking, low oxygen saturation at bedside oximetry, 80%, and agitation or confusion. 5 areas of potentially severe bleeding are chest, abdomen, pelvis, long bone fractures, external bleeding. At the end of a major survey, detect or exclude the following 5 serious problems: airway obstruction, massive hemothorax, flailed chest, cardiac tamponade, and finally pneumothorax, whether open or closed. Hemorrhage. Hemorrhage can be classified according to site, type of disrupted vessel, timing in relation to the onset of trauma, and etiology. Site, external or internal. External, visible as it occurs through skin wounds or from body orifice as in epistaxis or hematemesis. Internal, interstitial, fracture hematoma, or in body cavities, hemoperitoneum and hemothorax. Type of disrupted vessel, arterial, the blood is bright red in color and comes in pulsatile jets. Venous, the blood is dark red in color and comes in a steady flow. Capillary, bleeding occurs as diffuse ooze of bright red blood. Timing in relation to the onset of trauma. Primary hemorrhage at the time of trauma. Reactionary, hours after trauma within 24 hours due to slipped ligature or dislodged clot as blood pressure rises. Secondary hemorrhage 1 to 2 weeks after trauma due to infection, eroding vessel wall. If large blood vessel is involved, it's fatal. Etiology, hemorrhage may be traumatic, pathological, or bleeding diathesis, traumatic, accidental, surgical, interventional, PTC, pathological, atherosclerotic, ruptured aortic aneurysm, inflammatory, bleeding peptic ulcer, neoplastic hematuria in renal cancer. Bleeding diathesis, increased traumatic and pathological bleeding, or cause spontaneous bleeding. Pathophysiological response to hemorrhage: stopping the bleeding, maintaining effective circulatory volume and perfusion. Stopping the bleeding, immediate vasoconstriction and entemer retraction, platelet plug, blood clotting, more effective when the vessel is completely transected than when there is a side tear, and traumatic than in pathological cases. Fibrous tissue in its base hinder the constriction. Veins normally contain 2/3 of the blood volume, you should know that. Maintaining effective circulatory volume and perfusion of critical tissues, brain and heart, at the expense of less critical tissues such as skin, skeletal muscle, and splanchnic area through neural factors. Number 1, it decreases stimulation of baroreceptor in the aortic arch and carotid sinus and atrial stretch receptors, leading to decreased normal inhibitory vagal and glossopharyngeal discharge to the vasomotor center, leading to sympathetic stimulation, leading to veins constriction, blood displaces into the heart, constriction of the arterioles, mainly of the skin, skeletal muscle, and splanchnic area, increased peripheral resistance, increased rate and strength of cardiac contraction, transcapillary refill, decreased in blood volume and arterioles constriction, leading to decreased capillary hydrostatic pressure. The interstitial fluid moves into capillaries, leading to increased blood volume and decreased viscosity. Endocrine response: catecholamines from adrenal medulla and nerve endings, increases heart rate and myocardial contraction and constriction of skin and visceral arterioles, increased ACTH, cortisol, growth hormone, and glucagon, leading to hyperglycemia, increasing the ECF osmolarity and withdraws water from the ICF, the renin-angiotensin-aldosterone system. Angiotensin II is a powerful vasoconstrictor and stimulates sodium and water retention by direct action on kidney and indirectly through aldosterone release. Vasopressin, antidiuretic hormone, absorbs water from the collecting tubules at high concentrations, leading to vasoconstriction. Renal hypoperfusion leads to juxtaglomerular cells of afferent renal arterioles secrete renin, splits angiotensinogen into angiotensin I, converted to angiotensin II by angiotensin-converting enzyme in the lung. Angiotensin-mediated vasoconstriction takes 20 minutes. Baroreceptor vasoconstriction takes seconds. This mechanism allows survival without therapy for losses up to 15% of the blood volume. Blood loss exceeding 10% stimulates antidiuretic hormone release. Blood volume is estimated as 70 ml per kilogram in adults and 80 ml per kilogram in children. Clinical picture of hemorrhage: symptoms: weakness and fainting, especially when standing. The patient feels cold and thirsty. Signs: mental status from anxious to drowsy but remains alert. Pulse and blood pressure with mild blood loss less than 500 milliliters remain normal. With more blood loss, tachycardia but stable blood pressure. With more progressive blood loss, progressive hypotension. Pulse pressure decreased, leading to steady pulse. Respiratory rate, tachypnea and air hunger due to chemoreceptor stimulation by hypoxemia and acidosis. Temperature, hypothermia, leading to coagulopathy. Skin pale, cold, and clammy with decreased capillary refill and collapsed veins. Oliguria, diminished renal perfusion, and we have comparison between class 1, 2, 3, and 4 for the hemorrhage. Class 1, according to blood loss in 70 kg average male, up to 15% or 0.75. Mental status, normal to anxious. Skin, normal. Capillary refill is normal. Pulse per minute, less than 100. Blood pressure, normal. Systolic and diastolic and pulse pressure are normal. Respiratory rate from 13 to 20. Urine is more than 30 milliliters per hour. Class 2, according to blood loss from 15 to 30%, 0.75 to 1.5 liters. Mental status, anxious to restless. Skin, pale and cold. Capillary refill, more than 2 seconds. Pulse per minute, 100 to 120. Blood pressure, normal supine. Diastolic blood pressure is raised and pulse pressure is low. We have the respiratory rate from 20 to 30 and urine from 20 to 30 milliliters per hour. Class 3, 30 to 40% blood loss or 1.5 to 2 liters. Mental status, aggressive to drowsy. Skin is pale and colder. Capillary refill exceeds 2 seconds. Pulse per minute, 120 to 140. Low blood pressure, low systolic, low diastolic, and low pulse pressure. Respiratory rate from 30 to 35, and urine is from 10 to 20 milliliters per hour. Class 4, blood loss is more than 40% or 2 liters. Mental status, drowsy to unconscious. Skin is pale and very cold. Capillary refill is more than 2 seconds. Undetectable. Pulse per minute is more than 140. Blood pressure is low. Systolic pressure, diastolic, and pulse pressure low. Respiratory rate more than 35, and for urine is from 0 to 10 milliliters per hour. Then we have estimating the blood loss. This is obtained from clinical data, types of injury, fractured tibia from 0.5 to 1.5, fractured shaft of femur 0.5 to 2 liters, and fractured pelvis 2 to 3 liters. Blood loss at operation equals the amount in the suction reservoir plus the amount mopped by swab weight after minus before operation, times 1.5 or 2. According to the operation magnitude, investigations, a blood sample obtained for CBC, including hematocrit value, coagulation profile, and cross-matching. Treatment: stop the hemorrhage by packing, pressure, and position. A skin wound is covered by addressing any clean material, and pressure is applied manually by sphygmomanometer cuff or by a bandage. Tourniquets are contraindicated due to complications unless the limb is going to be amputated. Pneumatic anti-shock garment, PASG, can tamponade lower limb, pelvic, and abdominal bleeding. Balloon tamponade is used in esophageal varices. Elevation of the limb above the heart level stops venous and decreases arterial bleeding. Restore the blood volume. 2 large bore cannula are inserted into peripheral veins in upper limb, and by cut down on long saphenous vein, blood is drawn for typing and cross-matching. Class 2, from 15 to 30% blood loss, 750 to 1000 milliliters. The replacement solution is lactated Ringer. The amount is 3 times the estimated deficit, nearly 3 liters, as crystalloids diffuse out of the capillaries. Administration: 2 liters are given as bolus and monitor the response. Definitive improvement: give remaining liter more slowly. Moderate improvement: inadequate replacement, continue bleeding, or myocardial insufficiency. Cardiac tamponade and tension pneumothorax must be excluded. Blood transfusion is started if bleeding is still active. Class 3 and 4, 30 to 40% and more than 40%. As for Class 2, but these patients need blood transfusion. Initial volume of transfused blood equals the estimated deficit, 1.5 to 2 liters. If a cell slaver is available, clean blood in thorax or abdomen can be aspirated, anticoagulated, and then transfused back into the patient. This is something called autotransfusion. Initial hematocrit value is often normal. RBCs and plasma are lost in the same ratio. 4 to 6 hours later, decreased hematocrit by hemodilution is caused by movement of interstitial fluid into the circulation, and because of crystalloid replacement of lost blood. Hematocrit less than 30 requires blood transfusion. Failure to respond to treatment is due to whether continuous bleeding, pump failure, tension pneumothorax, cardiac tamponade, or cardiac contusion. Pump failure is distinguished by high central venous pressure reading or irreversible shock. Failure to improve and central venous pressure increased, we suspect tension pneumothorax, cardiac tamponade, or cardiac failure. If excluded and patient doesn't improve, then major thoracic, abdominal, or pelvic injury is usually present and needs immediate operation. Continue till hematocrit becomes 30%, urine output 50 milliliters per hour, central venous pressure increased to upper half of the normal range. Optimize oxygen delivery. For Class 2 hemorrhage, 40% of oxygen is given. For Classes 3 and 4, 100% oxygen. If raising oxygen carrying capacity by blood transfusion doesn't improve oxygen delivery, intubation and mechanical ventilation, and using inotropes such as dopamine and dobutamine, vasodilators and vasopressors. Monitoring: aim, prevent clinical sequelae and complications as cardiac arrest, acute respiratory distress syndrome, acute renal failure, GIT dysfunction, stress bleeding, DIC. A Foley catheter is necessary to monitor urine output, serial rectal temperatures, hematocrits, and cardiac monitoring, ECG for early detection of shock-induced arrhythmias. In old patients or has compromised cardiac reserve, Class 3 or 4, hemorrhage, or doesn't respond well to initial crystalloid administration, invasive monitoring, central venous pressure, blood gases, and blood lactate, index of anaerobic metabolism, a pulmonary artery catheter to monitor function of the left side of the heart. Blood transfusion, common blood products, packed red cells, very useful in anemic, elderly, and cardiac patients as it improves oxygenation without circulation overload. Fresh plasma, rich in platelets and coagulation factors. Fresh frozen plasma, plasma removed from flesh blood, rapidly frozen and stored at negative 40 degrees Celsius. A good source of all coagulation factors, useful with hemophilia, Christmas disease, and liver failure. Platelet concentrates, useful in thrombocytopenia, should be freshly prepared as half-life of platelets is very short. The amount obtained from 1 unit of blood increase the circulating number of platelets by 10,000 to 15,000 per microliter. Cryoprecipitate, it's stored at negative 40 degrees Celsius, prepared from FFB, and is very rich in factor VIII and fibrinogen. FFB is fresh frozen plasma. It's no longer recommended to transfuse fresh blood to correct coagulopathies. The specific deficient component should be used. For standard transfusion, blood is collected into citrate anticoagulant solution, which also contains dextrose to preserve RBC's viability during storage. One blood bag unit contains 70 to 100 milliliters of anticoagulant and 400 to 450 milliliters of blood. Blood must be kept at 2 to 6 degrees Celsius during storage. And then we have comparison between the product, indication, precautions, and storage life. Product, whole blood, indication, class 3 and 4 hemorrhage, precautions, ABC and RH, storage life 21 days, red cell concentrates, severe anemia, indication, precautions, ABC and RH, storage life is 21 days, fresh frozen plasma, indications are bleeding due to non-specified coagulation factor deficiency or coumarin overdose, precautions, ABO, storage life 1 year at 40 degrees Celsius, minus 40 degrees Celsius, platelet concentrates, primary or secondary thrombocytopenia, precautions, ABO, storage life 24 to 72 hours, cryoprecipitates of factor VIII and fibrinogen, indication, bleeding with fibrinogen depletion, precautions, ABO, storage life 1 year at minus 40 degrees Celsius, factor VIII for hemophilia A, storage life 2 years, factor IX for hemophilia B and coumarin overdose, and albumin 5% or 20% for acute volume expansion hypoalbuminemia, storage life is 4 years. Possible complications of blood transfusion, we have immunological complications of blood transfusion, and number 2, congestive cardiac failure, transmission of infection, hyperkalemia, citrate intoxication, air embolism, transfusion-related acute lung injury, TRALI, and complications of massive blood transfusion. Immunological complications of blood transfusion, incompatible RBCs, acute hemolytic reaction, incompatible white BCs, pyogenic reaction, incompatible platelets, purpura, reaction to a protein in the plasma leads to allergic reaction. Hemolytic reactions due to presence of antibodies in the recipient's blood against antigens in the donor's red cells. Clinical picture after transfusion of less than 50 milliliter, fever, chills, constricting pain in the chest, dyspnea, pain in the flanks, tachycardia, and hypotension. In an anesthetized patient, sudden tachycardia, hypotension, and bleeding tendency. A major hemolytic reaction, hemoglobinuria, jaundice, acute renal failure, consumption, coagulopathy, and generalized bleeding tendency. Treatment, stop the transfusion immediately. Repeat typing and matching. Correct shock by infusion of crystalloid solution, lactated ringer, and IV corticosteroids. Insert a Foley catheter to monitor urine output. An osmotic diuretic as mannitol may be needed to keep urine alkaline by IV bicarbonate to protect against acute renal failure. And finally, if acute renal failure develops, it must be treated. Pyrogenic reactions, the most common complication due to presence of recipient antibodies against the donor's white BCs. Clinical picture, chills, fever, headache, nausea and vomiting. Treatment, stop transfusion and give IV aspirin or paracetamol. Post-transfusion purpura in patients who have been previously sensitized to a foreign platelet antigen. Allergic reactions due to antibodies in the recipient against proteins in donor's plasma. Clinical picture ranges from mild itching and urticaria to severe reaction with laryngeal edema and collapse. Treatment, antihistaminics and corticosteroids. In severe reaction, stop blood transfusion. Congestive cardiac failure occurs in elderly persons, especially if large volume of blood is administered too rapidly. Prevention, transfuse packed RBCs rather than the whole blood to correct anemia in elderly persons. Transmission of infection, viral hepatitis B or C, the most common, transmitted by whole blood or blood products, obligatory to test donor for it. AIDS infection, transmitted by blood or its products. Septicemia, bacteria can survive but can't multiply in refrigerated blood. If the blood is allowed to warm, bacteria grow and gram-negative endotoxins can cause septicemic shock. Malaria, transmitted by RBCs only. Syphilis, can't survive at blood bank temperature for more than 4 days. Syphilis cannot survive at blood bank temperature for more than 4 days. Hyperkalemia with prolonged blood storage, progressive loss of potassium from erythrocytes into plasma, transfusion of several units of aged blood leading to arrhythmias or arrest. Citrate intoxication, excess citrate will bind to recipient's calcium, leading to hypocalcemia, augmenting effects of hyperkalemia on myocardium. Prevention: if more than 2 units of blood are administered, give 10 milliliters of 10% calcium gluconate for each 2 units of blood. Air embolism. Transfusion-related acute lung injury, TRALI. It occurs due to incompatibility between donor's antibodies and recipient granulocytes. Clinical picture similar to acute respiratory distress syndrome. Complications of massive blood transfusion. Definition: transfusion of 2,500 milliliters of blood at one time or 5,000 milliliters or more over 24 hours. Hypothermia: special warming unit should be used to warm blood before transfusion as hypothermia, leading to acidosis and arrest. Hyperkalemia, hypocalcemia, coagulation failure as stored blood is poor in platelets factor 8 and factor 5. Prevention: transfuse 1 unit of fresh frozen plasma and platelets for every unit of stored blood. Diminished oxygen carrying capacity of RBCs. Alternatives to homologous blood transfusion: we have autologous blood transfusion and preservation of the blood lost during surgery and its reinfusion to the patient. It needs a special apparatus. It's called cell saver. Autologous blood transfusion: a patient who is going to have a major elective operation can donate some units of his own blood over several days, kept in the refrigerator, to be given back to him during surgery. And this concludes our part for blood transfusion, trauma, and hemorrhage.